Welcome to today's deep dive. Today we are looking at what happens when a medical fix, quietly morphs into a medical nightmare.
Yeah, it's a pretty heavy topic today.
It really is. I mean, usually when we talk about a diagnosis, there is this expectation of like engineering level precision, right? You break your arm, the x-ray shows that jagged white line, the doctor points to it, and you have your answer.
Right, it's completely binary, broken or not broken.
Exactly. But when you step into the world of pelvic reconstructive surgery, and specifically synthetic implants, that clear diagnostic picture just completely shatters.
It really does. It becomes very murky.
Very murky and deeply impactful for anyone going through it. So we are specifically looking at surgical mesh today and what happens when the synthetic materials that are meant to support our bodies actually turn against them and carve their way through internal organs.
Yeah, it is a profound shift from how we normally think about healing. Our focus today is strictly on a highly specific medical phenomenon. We're looking at the clinical signs of synthetic mid-urethral sling mesh erosion into the vagina or urethra.
Which sounds incredibly niche, I know.
It does, but the implications are massive for the people experiencing it.
Right. And to give you, the listener, a complete picture, we are synthesizing a really diverse stack of sources today. I mean, we have clinical urology guidelines outlining the standard of care. We have these incredibly detailed medical case studies from RSNA journals and the American Urological Association.
And crucially, we are layering in legal summaries from personal injury attorneys, too.
Yes, the legal stuff, which is so interesting because those legal perspectives provide this stark look at the long-term, real-world aftermath of these surgeries that the clinical data sometimes just glosses over.
They absolutely do. It's a very different perspective.
So, okay, let's unpack this. Before we get into the nightmare scenario, we should probably establish why this mesh is inside the body in the first place, right?
Yeah, that's a good place to start. So mid-urethral slings are considered a frontline, very common treatment for stress urinary incontinence.
Which is the leakage of urine during moments of physical stress, like coughing, sneezing, laughing, or picking up something heavy.
Exactly. And the surgery is conceptually brilliant, honestly. Surgeons use this small strip of synthetic mesh, which is typically made of a plastic called polypropylene, to create a little hammock under the urethra.
Okay.
It basically reinforces weakened tissue and it stops the leaking.
Conceptually brilliant, sure. But as our sources show, mechanically fraught. I mean, the human body is this dynamic, constantly shifting environment, right?
Right.
And polypropylene mesh is relatively rigid.
Yeah, it doesn't move the way human tissue moves. And the clinical term you will see across all the urological literature for when this relationship fails is erosion.
Right, erosion. I also saw it called exposure or extrusion in some of the papers.
Yeah, they use those terms interchangeably. But what it actually means is that the synthetic mesh slowly wears through the surrounding human tissues, and it enters spaces it should just never be in.
Like it pushes its way into the vagina, the urethra, the bladder, or just other areas of the pelvic floor.
Exactly.
When I was reading through the sources and trying to visualize this whole process, it really reminded me of a wire fence that someone wraps around a young sapling to keep it growing straight.
Oh, that's a really good analogy.
Yeah, because over time, that tree grows, right? It shifts, it expands, it sways in the wind. But that rigid metal wire doesn't adapt or grow with the tree at all.
It just stays exactly where it is.
Right. And eventually, the tree's movement against that stationary wire causes the metal to slowly embed itself, pushing right through the bark and permanently lodging into the wood. The tree essentially grows through its own restraint.
And causes severe damage in the process.
Yeah, that is a highly accurate way to picture the biological battle that's happening in the pelvic floor.
It's just wild to think about that happening inside a person. It is, and the sources break down the exact surgical and physical mechanisms that cause this. Sometimes the erosion is initiated just by the placement technique itself.
Like if the surgeon puts it in wrong.
Well, wrong is a strong word, but if the sling is placed too deep into the periurethral fascia, which is the connective tissue wrapping the urethra, or even too close to the delicate mucosal lining, the margin for error just completely disappears.
Ah, I see.
The mesh basically begins rubbing directly against vital structures from day one.
Wow. It sounds like placing this requires an almost impossible level of precision. Because the sources also mention tension being a huge factor.
Yes, tension is critical.
Like If the surgeon pulls that mesh hammock even a fraction too tight to make sure the incontinence stops, they trigger something entirely worse. They're essentially starving the local tissue of oxygen, right?
Yeah, that mechanism is known clinically as ischemic necrosis.
Ischemic necrosis.
Right. The tension from the tightly pulled mesh cuts off the microscopic blood vessels that supply the surrounding tissue. And without that blood flow, the tissue is deprived of oxygen and nutrients, and it literally just dies off.
That is horrifying.
It is. And once that barrier of healthy tissue necrotizes and vanishes, there's absolutely zero physical resistance stopping the mesh from eroding right through into the adjacent organs.
But we can't just blame the surgical technique, right?
Yeah,
Because the sources point out that the physical properties of the mesh itself can be the culprit too.
absolutely. The material matters a lot.
Because polypropylene mesh is designed with these microscopic pores to encourage human tissue to grow into it and anchor it in place.
Right, that's the whole idea behind the design.
But if those pores are too small, or if the plastic is simply too stiff and lacks elasticity, the body just fails to incorporate it.
Yeah, the immune system basically recognizes it as a foreign invader. It fails to integrate it, and the rigid plastic ultimately wins the physical battle against the soft tissue.
Which brings up one of the most unsettling findings in the clinical literature, at least for me.
Oh, the silent cases.
Yes, because this erosion is often a slow, microscopic process of friction and cellular death. Sometimes the body doesn't trigger a massive pain response immediately.
Right. Mesh erosion can present with absolutely zero symptoms. It can be a completely silent threat.
That was the ultimate aha moment for me in these sources. A woman might be going about her life for months or even years, feeling totally fine and completely unaware that this strip of plastic has carved its way through her internal tissue.
It's terrifying.
And then the erosion is only discovered incidentally,
Yeah.
during a routine pelvic exam when the doctor physically sees it.
Yeah, the silent cases are terrifying from a diagnostic standpoint,
Yeah.
but unfortunately they are not the norm.
No, they're definitely not.
When the body does mount a defense or when the physical damage reaches a critical threshold, the symptoms are incredibly disruptive.
So let's talk about those symptoms. What does it actually look like?
Well, if we look specifically at what happens when the mesh erodes outward into the vaginal wall, the clinical presentation is essentially a story of the body's immune system fighting a war. It just cannot win.
Right.
You see persistent vaginal bleeding, unexplained spotting, and highly unusual discharge.
Which makes complete biological sense when you really think about it. I mean, the body detects this exposed, rough plastic protruding through the vaginal wall, registers it as an open wound or like an intruder, and just sends inflammatory cells to fight it off.
Exactly. The constant discharge and irritation are just the byproducts of this endless immune response. The body is constantly trying to heal over a foreign object that simply refuses to be absorbed.
And beyond the immune response, there's the brutal physical reality of the exposure. The sources detail how patients or their partners might actually feel a rough, sharp, or jagged area of the mesh protruding directly into the vaginal canal.
Yeah, the tactile reality of that is just deeply unsettling.
It really is, and that leads directly to dyspareunia, right?
Yes. Dyspareunia is the medical term for severe pain during sexual intercourse. Both the patient and her partner can experience sharp pain or even physical trauma simply because the synthetic material is acting like exposed wire inside the vaginal vault.
We need to dive deeper into the pain profile here because the legal summaries in our sources paint a picture that the clinical guidelines sometimes seem to minimize.
They do tend to gloss over the day-to-day reality of it.
Right. I mean, if you have any surgery, you expect a few weeks of soreness. But we aren't talking about post-surgical healing here. The legal documents specifically describe chronic pelvic pain lasting well over 6 months.
Which fundamentally alters a patient's quality of life. The legal sources are vital here because they really capture the patient's lived experience. The pain profile isn't just some vague discomfort.
Oh, not at all.
Women describe a constant heavy baseline ache deep in the pelvic region. You have to remember the nerves in the pelvic floor are incredibly dense, and as the mesh erodes, it can entrap or severely irritate these nerve pathways.
So is this a constant pain, or does it come and go?
It's typically a constant dull ache that is then punctuated by sudden, sharp exacerbations.
Oh, wow.
Yeah, bending over, lifting a grocery bag, or sometimes just shifting in a chair can trigger a blinding spike of pain as that rigid mesh pulls against scarred nerve tissue.
Okay, I have to push back here. Or rather, I want to challenge the medical establishment's logic based on what we are reading.
Sure, go for it.
If this synthetic polypropylene mesh carries this horrific, unique risk of chronic nerve pain and physical erosion, why is it considered a very common treatment?
That is the million-dollar question.
Right, because the sources even mention that the American College of Obstetricians and Gynecologists, ACOG, states that natural tissue slings don't carry these specific erosion risks. Why aren't surgeons just exclusively using a patient's own tissue to build the sling?
It raises a really important point, and it ultimately comes down to a difficult calculus of surgical efficiency versus long-term risk.
Efficiency over risk.
Okay. Yeah. Natural tissue slings, where a surgeon harvests a strip of fascia from the patient's own abdomen or leg to create the hammock, they are highly effective. Your body won't reject its own tissue.
Makes sense.
However, it requires a much more invasive, longer surgery with 2 incision sites and a significantly longer initial recovery time.
I see.
The synthetic mid-urethral sling was popularized because it is a fast, minimally invasive outpatient procedure. It basically revolutionized incontinence treatment because it was just so easy to perform.
But as we're seeing, the trade-off for that immediate surgical convenience is the introduction of a permanent non-biological material.
Exactly. One that carries a lifelong risk of mechanical failure.
So it's basically a matter of prioritizing a quick fix over the complex reality of how the human body ages.
Sadly, yes.
Well, that perfectly transitions us to the other side of this anatomical disaster. If vaginal erosion is a story of physical exposure and nerve entrapment, urethral and bladder erosion is a story of paradoxical mechanical failures.
Yes, paradoxical is the perfect word for it.
This was honestly the most baffling part of the source material for me. Like, you get a bladder sling to stop stress, urinary incontinence, you want to stop leaking. But the complications of the mesh eroding actually cause the exact symptoms the surgery was meant to fix.
What's fascinating here is the chain reaction of urethral erosion. When the mesh begins wearing inward, pushing through the delicate lining of the urethra, it causes severe voiding dysfunction.
Okay, voiding dysfunction.
Right. The sling, which may have shifted or contracted or scarred over, becomes a physical barricade. It blocks the flow of urine, leading to urinary retention.
So the patient physically cannot empty their bladder, even when they desperately need to.
Exactly. They might struggle to start a stream, they might experience a weak or intermittent flow, or just constantly feel a sensation of incomplete emptying.
That sounds miserable.
It is, and because that residual urine is just sitting stagnant in the bladder, it becomes a perfect breeding ground for bacteria.
Oh, of course.
This leads to chronic, recurrent urinary tract infections that simply won't resolve with standard antibiotics, because the underlying mechanical blockage is still there.
But the clinical profile of this urinary dysfunction isn't static, right? The sources map out this fascinating and honestly somewhat deceptive timeline shift.
Yes, the timeline is absolutely critical for diagnosis here.
Because what a patient experiences a month after surgery is completely different from what they experience a year later.
Exactly. In the early stage, which is weeks to a few months post-op, the symptoms are dominated by those voiding difficulties we just discussed: retention, struggling to pee, and symptoms of urethritis.
Which is severe inflammation and burning in the urethra.
Right, as it reacts to the surgical trauma and the physical presence of the mesh.
But then as months or years pass and the erosion progresses, the entire symptom profile just flips on its head.
It does. In the late stage, the mechanical support of the sling completely fails, and you see a full relapse of the stress urinary incontinence. The leakage returns.
Wow, all that for nothing.
But crucially, you also see the onset of de novo urgency.
De novo meaning new.
Yes. This is a sudden, intense, overwhelming urge to urinate that the patient never had before the surgery. As the mesh irritates the nerves of the bladder and urethra, it causes the bladder muscle to become hyperactive and spasm uncontrollably.
That is just awful.
Add to that the continued UTIs and the appearance of hematuria, which is visible blood in the urine caused by the mesh physically scraping the urinary tract lining, and the diagnostic picture becomes incredibly complex.
Okay, here's where it gets really interesting and honestly a bit mind-blowing.
Oh, the case study.
Yes. Our sources include this highly specific medical case study documenting the extreme end of this late-stage timeline. So 2 women presented to their doctors 18 and 22 months after their initial sling surgeries, almost 2 years later.
Right. A significant amount of time had passed.
And they were suffering from bloody urine, endless UTIs, and severe voiding pain. But when the doctors finally looked inside, they didn't just find mesh that had eroded completely through the bladder wall. They found what the study calls vesicle stone formations.
Yes, that part is incredible.
Bladder stones had literally crystallized and grown directly onto the exposed plastic mesh inside the organ.
It really is a stunning visual of the body's defense mechanisms backfiring. The urinary tract is highly sensitive to foreign objects.
Really?
So when the synthetic mesh breaches the bladder lining, it acts as a nidus, a focal point. The natural minerals and salts in the urine, like calcium and oxalate, begin to precipitate and calcify around the plastic threads.
So they literally grew stones.
Yes. Layer by layer, these minerals build up over months, forming hard, jagged stones permanently anchored to the mesh. It perfectly illustrates why these late-stage complications cause such excruciating pain and bleeding. The body is essentially manufacturing its own internal shrapnel.
That is just wow. So how does the medical field actually handle this? If you are a doctor trying to prevent this, or a patient worried about it, how is it discovered? Because you can't just put a patient in a standard X-ray machine and see a piece of plastic or a microscopic tissue erosion.
Well, prevention is the first line of defense, and it has to happen while the patient is still on the operating table. The American Urological Association guidelines are incredibly strict about this.
Okay, what do they require?
During the initial sling placement, a procedure called intraoperative cystourethropy is absolutely mandatory.
Instead of just reading the medical term, let's look at what the surgeon is actually doing during that procedure.
Yeah.
What are they looking for?
So while the patient is under anesthesia and the sling has just been placed, the surgeon inserts a highly specialized, thin tube with a camera and a light on the end directly through the urethra and up into the bladder. They must visually inspect the entire inner lining of the urinary tract on a monitor. They are actively hunting for any immediate punctures. Did the surgical needles accidentally pierce the bladder? Did the mesh slice through the urethra during tensioning?
Just making sure they didn't accidentally stab anything they shouldn't have?
Exactly. Whether they used a retropubic approach behind the pelvic bone or a transobturator approach through the groin, this visual sweep is completely non-negotiable to catch immediate surgical errors.
But, as our timeline showed us, catching an immediate puncture during surgery doesn't prevent the slow-motion erosion that happens 2 years later.
Right. The tree still grows around the wire.
Exactly. So if a patient comes in years later with blood in their urine or chronic pain, and a camera confirms the mesh has eroded, how on earth do surgeons fix it?
The surgical intervention is dictated entirely by geography. Where exactly has the mesh breached?
Okay, let's say it's vaginal.
If it is a vaginal erosion, the surgeon must operate through the vaginal canal, carefully dissect the tissue, surgically snip and remove the exposed portion of the plastic mesh, and then suture the healthy vaginal tissue back together. And then they just hope it heals over the remaining embedded plastic.
Wait, they leave some of it in?
Often, yes.
Yeah.
Taking it all out can cause even more damage.
Wow. Okay, but what if it has breached the bladder and grown stones, like the women in our case study? You can't exactly stitch that up easily.
No, bladder and urethral erosions require a much more delicate endoscopic approach. They really don't want to cut the bladder open from the outside if they don't have to. Returning to that specific case study, the surgical team utilized a technique called pneumatic lithotripsy.
Which sounds incredibly intense for being inside a bladder.
It is basically a microscopic pneumatic jackhammer fed through a camera tube. The surgeon uses compressed air pulses to repeatedly strike the calcified bladder stones, physically smashing them into tiny fragments that can then be flushed out of the bladder with fluid. And once the stones are destroyed and the mesh is fully exposed, they deploy a 26 French resectoscope.
And this isn't a traditional scalpel? The sources said we were talking about feeding an electrified wire loop into the bladder to cut plastic away from living tissue.
Exactly. The resectoscope uses a specialized wire loop charged with high-frequency electrical current. It acts as an energetic knife, simultaneously cutting away the exposed polypropylene mesh and cauterizing the surrounding bleeding tissue.
That sounds terrifyingly delicate.
It is an incredibly precise, high-stakes procedure. In the case study we reviewed, a follow-up cystoscopy 3 months later showed a complete success. The bladder mucosa had naturally healed over the surgical site, and both patients were continent and entirely free of their painful symptoms.
Okay, well, that is a phenomenal outcome for those 2 specific patients. But I think it is vital we ground this discussion in the sobering reality presented by the totality of our sources, especially those legal summaries.
Yes, the big picture is much more complicated.
Because for anyone listening, if you or someone you love is navigating this medical maze, Understanding the long-term stakes is crucial. The clinical literature is very upfront. Even with a technically successful partial excision cutting away just the exposed mesh, there is a high risk of recurrent erosion.
Because the underlying problem hasn't necessarily been solved. The remaining embedded mesh can simply continue its slow march through the tissue, meaning the patient might face the exact same nightmare a year later.
And the legal perspectives highlight a darker truth, honestly. In many circumstances, the adverse effects are permanent.
Yeah, that's the hardest part to hear.
Removing the mesh does not magically repair the dense networks of nerves that were crushed, severed, or scarred during the years the mesh was eroding. The chronic pain, the loss of intimacy due to dyspareunia, the permanent alterations to urinary function, these can be lifelong burdens even after the plastic is gone.
If we connect this to the bigger picture, the absolute key takeaway for both patients and healthcare providers is unrelenting vigilance. Any persistence of lower urinary tract symptoms, any new onset of pelvic pain, or any unexplained UTIs years after a mid-urethral sling procedure must be treated as a massive red flag.
You can't just brush it off.
Right. You cannot dismiss it as a normal part of aging. You cannot assume it is just a stubborn infection. The sources are definitive. Long-term follow-up is an absolute requirement for any patient living with synthetic mesh.
Especially considering that the medical community itself is still struggling for answers.
Precisely. The literature openly acknowledges that the optimum, safest method for complete total mesh excision hasn't even been universally determined yet.
Really?
Yeah, trying to completely extract a porous plastic mesh that the body's tissue has grown through is like trying to pull rebar out of set concrete without destroying the building. Medical science is still actively trying to figure out how to safely navigate this.
That is a heavy but deeply necessary truth to understand. So what does this all mean? To summarize the incredible terrain we've covered today, the clinical signs of synthetic mid-urethral sling mesh erosion span a vastly unpredictable spectrum.
They really do.
It can be a completely silent anatomical failure discovered entirely by accident. It can present as chronic, sharp vaginal pain, endless immune discharge, and painful intercourse.
Or it can manifest as a delayed, paradoxical nightmare where a surgery meant to cure incontinence causes severe urinary retention, new hyperactive urgency, and literally acts as the foundation for bladder stones to grow years after the fact. It serves as a stark, clinical reminder that whenever we introduce rigid synthetic materials into the fluid, dynamic, and constantly aging environment of the human body, we are introducing variables that can take years or even decades to fully reveal their consequences.
Which brings me to a final thought I want to leave you with today. We talked earlier about that rigid wire fence slowly embedding itself into the trunk of a growing tree.
Yeah, that image really sticks with you.
It does. And if a synthetic material designed with the best intentions to support our bodies can slowly erode through vital tissues, cause permanent nerve damage, and literally harvest stones from our own urine, it makes you wonder about the entire future of medical implants.
It really does beg the question.
Like, how close are we to a paradigm shift? How long until we move past plastics and titanium and finally create true bio-integrated materials? Implants that don't just sit rigidly inside us fighting a lifelong war against our immune systems, but actually adapt, regenerate, and live in true, living harmony with our shifting anatomy.
That is the ultimate goal.
Until we reach that medical frontier, being informed, vigilant, and asking the hard questions is our best defense. Thank you so much for joining us for today's deep dive.